You're 800 feet underwater, 2,000 miles from land. A sailor is dying from a ruptured appendix. There's no doctor on board, no operating room, no anesthesiologist. Just a Navy corpsman, a dining table, and a decision that could save a life or end it. This is the reality of submarine medicine. And what happens next will blow your mind. Chapter 1. The medic who isn't a doctor. Here's something most people don't know. US Navy submarines don't carry doctors. Not on fast attack boats, not on guided missile submarines. The sole medical provider on a sub with 160 crew members is an independent duty corpsman, or IDC. This isn't some basic first aid guy. An IDC goes through approximately 12 months of intense, compressed medical training. They're essentially a physician assistant, paramedic, and emergency room nurse rolled into one. They can suture deep lacerations, pull infected teeth, reduce fractures, insert chest tubes, and manage medical emergencies that would send most people into panic mode. But here's the catch. Their official scope of practice is primary care and emergency stabilization. They're not surgeons. They're not trained to open someone's abdomen and operate on internal organs. Yet, in the worst case scenario, that's exactly what they might have to do. An IDC I spoke with put it bluntly. You're the only medical person on a boat carrying nuclear weapons, operating in one of the most hostile environments on Earth. If something goes catastrophically wrong, you're it. There's no calling for backup, there's no ambulance. It's you, your training, and whatever you can improvise. Chapter 2. The dining table operating room. If a submarine medic has to perform emergency surgery, there's no operating room to rush to. There's the wardroom, the officer's dining and meeting room. The same table where the captain eats breakfast becomes the operating table. The conversion process is rigid and rehearsed. The wardroom table is bolted to the deck, which provides stability. The submarine will seek a deeper depth, usually over 150 feet, to minimize roll and pitch from surface waves. You need a stable platform when you're cutting into someone's body. Lighting is critical. You can't operate under standard fluorescent deck lighting. It casts shadows and isn't bright enough for precision work. Submarines carry a specific portable surgical light, NATO Stock Number 6 530-0-0-185-0034 that connects to the ship's 110-volt auxiliary power circuit. In emergencies, crew members have rigged high-intensity battery-powered battle lanterns to overhead piping using tape, creating makeshift spotlights. The atmosphere itself is a challenge. Submarines operate in a closed-loop environment. You can't use volatile anesthetic gases like ether anymore because they're explosive and the air scrubbers can't remove them. Modern submarine anesthesia relies on IV drugs, primarily ketamine or propofol. Ketamine is the drug of choice in austere environments because it keeps the patient unconscious but maintains their respiratory drive. They keep breathing on their own, which is critical when you don't have a ventilator or an anesthesiologist. Sterilization is another problem. There's usually a small autoclave in the medical office for sterilizing instruments. If that fails, the backup is boiling water in the galley or using cold chemical sterilization with glutaraldehyde. Not ideal, but better than nothing. Chapter 3. The team that never trained for this. An IDC cannot perform surgery alone. He needs help. That's where the Emergency Medical Assistance Team, or EMAT, comes in. These aren't medical personnel. They're regular crew members, sonar technicians, cooks, yeomen, mechanics. They've received extra training from the IDC to pass instruments, hold retractors, monitor vital signs, and assist during medical emergencies. But they're not nurses. They're sailors who happen to have some medical training because someone has to help if things go sideways. Imagine being a sonar tech whose normal job is tracking contacts and analyzing acoustic data. Now you're standing over your shipmate, holding a retractor to keep an incision open while the IDC operates on a ruptured appendix. The room smells like betadine and blood. The patient is sedated but moaning. Your hands are shaking. And you know that if this goes wrong, your friend dies. That's the reality of EMAT. These guys are heroes who never signed up to be surgical assistants, but they do it anyway because there's no other option. Chapter 4. The Appendicitis Protocol. Appendicitis is the classic submarine medical nightmare. It's common enough to be a real threat, and it's deadly if not treated. A ruptured appendix leads to peritonitis, sepsis, and death within days if untreated. Modern submarine doctrine is clear. Do not operate unless absolutely necessary. The protocol is called the Oshner-Sharon regimen, named after the surgeons who developed it. Aggressive 4 antibiotics, usually rocephin or ertapenem. IV fluids to maintain hydration. Bowel rest, meaning nothing by mouth. The goal is to cool down the inflammation and prevent rupture while the submarine races to a medevac point. This works surprisingly well. The appendix inflammation can be controlled for days, sometimes weeks, giving the boat time to reach a port or rendezvous with a surface ship for medical evacuation. The sailor gets proper surgical care in a real hospital, and the IDC doesn't have to attempt a procedure he's not trained for. But what if the appendix ruptures before evacuation is possible? What if the submarine is under polar ice or in a combat zone where surfacing means death? What if medevac simply isn't an option? Then the IDC has to make the call: operate or watch the sailor die. Chapter 5. Consulting the Heavens. Here's where modern technology provides a lifeline. If an IDC has to cut, he's never truly alone. The submarine can come to periscope depth, raise the photonics mast or float a communications buoy, and establish contact with shore. On the other end of that satellite link is a submarine force medical officer, a real surgeon, someone who has performed hundreds of appendectomies and can talk the IDC through the procedure step by step. This is called consulting the heavens, and it's as close to a miracle as submarine medicine gets. The shore-based surgeon can provide real-time guidance: where to make the incision, how deep to cut, what to look for, how to identify the appendix, how to ligate blood vessels, how to close the wound. It's remote surgery by voice communication, and it has saved lives. But there's a catch. The submarine has to maintain communications, which means staying at periscope depth. That's a vulnerable position. If the boat is in hostile waters, maintaining comms for an extended period could compromise the mission or endanger the entire crew. The captain has to weigh the life of one sailor against the safety of 159 others and the strategic importance of the mission. It's a decision no one wants to make. Chapter 6. The Legendary Case. The most famous submarine surgery in history happened in 1942 aboard the USS Sea Dragon during World War II. Pharmacist's mate Wheeler Lipes performed an emergency appendectomy on Seaman Darrell Rector while the boat was in enemy waters. Lipes had never performed surgery. He had a basic medical manual and some guidance from a doctor via radio before the boat had to dive and go silent. The tools he had were absurdly inadequate: bent spoons for retractors, a tea strainer covered with gauze as an ether mask, and torpedo alcohol for sterilization. The surgery took over 2 hours. Lipes made the incision, found the appendix, removed it, and closed the wound. Rector survived. The story became legendary, proof that it could be done. But here's what people forget. Lipes got lucky. The appendix hadn't fully ruptured. The infection was contained. Rector was young and healthy, and most importantly, nothing went catastrophically wrong during the procedure. If a major blood vessel had been nicked, if the infection had spread, if any of a dozen complications had occurred, Rector would have died on that table. Modern IDCs know this story. They respect it, but they also know that luck isn't a medical strategy. Chapter 7. The Modern Reality. Fast forward to 2005, the USS San Francisco, a Los Angeles-class fast attack submarine, hit an uncharted seamount at full speed. The impact was catastrophic. One sailor was killed instantly. 98 others were injured, many seriously. Head trauma, broken bones, internal injuries, severe lacerations. The IDC on board did not start performing surgeries. He triaged. He stabilized airways. He treated head trauma. He managed shock. He controlled bleeding. He kept people alive while the boat fought to surface, and the crew worked to save the ship. Once on the surface, the most seriously injured were evacuated by helicopter to Guam for proper medical care. The IDC's job was to keep them alive long enough to reach real surgeons in real hospitals. That's the modern doctrine. Stabilize and evacuate. Don't attempt heroic surgery unless there is absolutely no other option. The technology exists to get help. Use it. Chapter 8. The equipment they carry. Every submarine has an Authorized Medical Allowance List, or AMAL. It's the packing list for medical supplies, and it includes a minor surgery kit. Inside that kit, scalpels with number 10, 11 and 15 blades, hemostats for clamping blood vessels, tissue forceps, retractors, sutures in various sizes, sterile drapes, surgical gloves. The drug locker includes powerful antibiotics like Rocephin and ertapenem for abdominal infections, pain management options including morphine and fentanyl, ketamine for sedation and anesthesia, local anesthetics like lidocaine for nerve blocks. There are 4 fluids, blood pressure cuffs, pulse oximeters, and basic monitoring equipment. There's a defibrillator in case of cardiac arrest. There are airway management tools including endotracheal tubes and a cricothyrotomy kit for emergency surgical airways. It's an impressive collection of medical gear, but it's still a far cry from a fully equipped operating room with surgical teams, anesthesiologists, and backup systems. It's enough to handle most emergencies and keep someone alive. It's not enough to perform complex surgery safely. Chapter 9. The psychological weight. Imagine being that IDC. You're 25 or 30 years old. You've had a year of medical training. You're good at your job. You've handled dozens of medical situations successfully. Now you're standing over a sailor with a ruptured appendix. You know that without surgery, he'll die within 48 hours. You know that attempting surgery could kill him on the table. You know that you're not a surgeon, that you've never done this procedure, that the conditions are terrible and the risks are enormous. But you're also the only chance he has. The captain is looking at you. The EMAT is waiting for orders. The crew is watching. And the sailor on the table is your shipmate. You've eaten meals with him. You've stood watch with him. You know his family. What do? This is the weight that submarine IDCS carry. The knowledge that someday they might have to make that call. Most will serve entire careers without facing that situation. But the possibility is always there, lurking in the back of their minds. One IDC told me, you train for the worst case scenario and pray it never happens, but if it does, you do your job. You do everything you can, and you live with the outcome, whatever it is. Chapter 10. The truth about submarine surgery. So here's the truth. Submarine medics almost never perform major surgery. The modern US Navy has protocols, communication systems, and evacuation procedures that make it extremely rare. The doctrine is clear: stabilize and get the patient to proper medical care. But the capability exists. The equipment is on board, the IDC is trained, the EMAT is ready. If the absolute worst case scenario happens, if a sailor's life depends on emergency surgery and there's no other option, it can be done. It won't be pretty, it won't be safe, the risks will be enormous, but it's possible. The wardroom table will be cleared and scrubbed down, the surgical light will be rigged, the EMAT will assemble, the IDC will open the medical kit, pull on sterile gloves, and pick up a scalpel. And somewhere, 800 feet underwater, in the middle of the ocean, in one of the most hostile environments on Earth, a surgery will be performed. Not because it's the best option, but because it's the only option. That's submarine medicine. That's what these IDCs sign up for. That's the job that most people never think about, but that keeps 160 sailors alive on every submarine patrol. They're not doctors, they're not surgeons, but when everything goes wrong and there's no one else to call, they're exactly who you want standing over you with a scalpel and the determination to bring you home alive. We are committed to releasing 3 videos a week. Like, share, subscribe, and hit the bell icon for more AnchorWatch.